The motion is, a pregnant woman with a difficult airway should have an elective caesarean section. So, Dr. Mushambi.
Good morning. Patients with a known difficult airway should have an elective caesarean section. Now, I know this consultant and this trainees, but I just want you to imagine that you're on the board tonight, okay? That's the weather. I know it's quite nice out there, but we go back to January or December or February. That's what the weather looked like. That's the trainee, that's how you got to work. And that's the consultant, house in the ditch, right? And so are your rest of your colleagues as well. This is ODP. Because the ODPs couldn't come in, you only have agency ODP, new to labour ward, never done obstetrics, and they hate obstetrics anyway. That's the patient. Okay, I know, I'm exaggerating a bit, but that's the reality. That's the patient I was looking after. Okay, so on this basis, I want you to think, would you like to face this in the middle of the night, or would you rather have them as an elective caesarean section? I'm going to spend the next 20 minutes arguing for it. Now, this is really what some people would say. That's a polite way of saying, why wasn't that patient done as an elective section? So, I'm going to concentrate on these 5 issues to try and really convince you that we should be doing difficult intubation patients during the day. I'm going to look at training issues, supportive staff such as ODP, recovery staff equipment, what CMS is telling us, and then some consultant issues, and then present you just a few cases just to show you very briefly some of the things that we've dealt with. Okay, so let's start off with training issues. I'm sure a lot of this I don't have to tell you, most of you know already. The hours have gone down because of the European Working Time Directive. And because of that, not only are we short of trainees, which is not my problem, that's a management problem, but they're short of experience. When I was a college tutor, and I finished 3 years ago, if trainees got 450 cases, they were doing pretty well. And I'm sure they do far less than that. Okay? And unfortunately, trainees still do the nights. They still do emergency work. We still do on calls from home. So you've got the trainee who's still working as a resident on the labour ward. Now, let's look at the training things that the trainees have already. Let's look at intubations. How are they getting on as far as learning intubations? Well, a survey was done to look at the intubations in a hospital near us. And they found that the number of intubations had gone down from 450 to 280 per year. Okay? Now that was mainly elective. It wasn't the emergency. The emergency was not much change, as you can see from there. Okay? But the LMA use had gone up. So trainees are not intubating. And also, somebody looked at who's actually intubating when. And again, because there are very few trainees, they're not there during the day, most of the intubations are being done by consultants, 50%. And the only time that trainees are being trained, 86% of the time. So, let's look at intubation. Let's look at caesarean sections. What's happening in the caesarean section rate? Well, general anesthetic for caesarean sections have gone down. Look at this, 1982, 425. We're now down to 41 GAs in a year. That's pretty, about 3 a month, very little. And then, if you look at how many trainees are actually giving a general anesthetic for a caesarean section, look at this, from 18 per sort of 3 modules that they might do, to 1. They can be experienced. You can't leave them at night to be having to give a general anesthetic on their own, or somebody with already a known difficult intubation. And in fact, when Johnson wrote a paper in 2000, his comment at the end was, GA for caesarean section may become a technique for which consultant presence is mandatory. Tell me, are we going to be able to achieve that in the middle of the night? No. Let's move on. Rapid sequence induction. We still know that rapid sequence induction is the classic induction for obstetric cases. Are they getting experience out there? Let's look at this. It's only really obstetrics that we're still doing the classic sodium thiopentone and sulfonylurea. Everybody else seems to be changing to using other drugs. So we're expecting them, when they do their 1 GA, to be using thiopentone and such, which they probably haven't used before, and they're going to be using for the first time in obstetrics. we're getting wrong somewhere here. Let's move on. Because of all this, failed intubations is going up. As you can see, looking at these large studies, 1 in 300 used to be 1 in 1984. It's now 1 in 249. Now those are the large studies, the ones on the left there. There's some smaller studies, which East has done 1 in our hospital in Leicester, 1 in 80, 1 in 200, and 1 in 46. That's frightening, isn't it? It's quite frequent. Now, why are people having failed intubation? Well, there's lots of reasons. It's training, experience, etc. But one of the ones that seems to be ignored quite often is airway assessment. Trainees and ourselves, we're not assessing the airway in anybody. If you look at this data, which was done a few years ago, look at this. In the emergency, you can understand if people don't assess the airway. Mouth opening, on 4.5%, check mouth opening. Malampati, 47%. That's in the emergency situation. But are we doing any better in the electives? No, we're not. Look at this, it's hardly anything. The only one that's above 55% is in extension. So they're not assessing the airway, and we're not teaching them assessment of the airway because we're not doing it during daytime either. So, here we are. Is it a problem if we don't assess the airway? Yes, it is a problem because this is what happened in the study where they looked at patients who had a failed intubation and say, let's examine them. What can we learn from it? And they found that in those patients, 40% actually had a receding jaw and 30% had limited mouth opening, which hadn't been picked up preoperatively. Would you have given somebody a GA if you knew that's their limited mouth opening? So we've got to tackle these things. Training, again, can't intubate, can't ventilate scenario. We carried out this survey to look at the training of the can't intubate, can't ventilate scenarios that was there. And 7% of the hospitals in the UK don't teach the scenario at all. And only 56% of units or hospitals in the UK actually have simulation and teach simulation. So we're not teaching much of this technique at all to trainees. So just to summarize the training issues that we haven't tackled is that, we have decreased number of cases, decreased intubations and teaching, reduced number of obstetric GAs, where trainees are not doing rapid sequence, the classic rapid sequence with thiopentone and succinylcholine, other than in obstetrics. Poor airway assessment, and we know that failed intubations are going up, and we're not teaching people how to cope with them. So now I'm going to move on to other problems that we might face. ODPs. Do you know about your ODPs? I have lovely ODPs, and I feel comfortable when they're around. But not all ODPs are experienced, particularly newer trained ones are not as experienced as the old ones. So, what we're going to do about it. We did a survey. I apologize, this is a busy slide, but don't worry. All I want to show you is that this is looking at ODP experience or knowledge of difficult airway equipment. So it's something like intubating LMA, C-track, fiber optic scopes, any of that, so that if you need it in a hurry, will they be able to help you? If you look at this red bar, that's 50% of the ODPs. And the ones before, most of the ones had no idea, had never heard of any of this equipment, or come across the equipment, except just the fiber optic scopes. So if you had problems out of hours, you would have, ODPs really have no idea how to assist you. Okay? Another survey which was done looking at cricot pressure, very crucial thing, because I think inappropriately applied cricot pressure is the commonest cause of failed intubation in obstetrics or when you're doing rapid sequence extraction. Is it applied appropriately? But they looked at, I know it's anaesthetists, OGPs, and nurses, and it's actually more worrying that some anaesthetists are involved in this. 37% could not volunteer the force that we need to use for applying cricot pressure. Only 13% stated the correct force. And when they were asked to press the force before training, look at the range. They were either applying very little or far, far too much, which obviously is going to cause a lot of problems. So there's another issue there that OGPs were going to be assisting us. Recovery at night, often empty, very few staff around. Do you want to put somebody who just had a general anesthetic with a difficult intubation into a recovery unit where there's not as many people around, nobody to call in a hurry? It's up to you. Move on to equipment that's available on the delivery suite. what equipment, we did a survey of all the units in the UK, and this is a slide showing what equipment. I'll just look at two things. If you look at fibre optic scopes, that's the no and that's the yes. So about 40% of the units actually had fibre optic scope on the delivery suite, which is interesting because, again, if you need it out of hours, you'd have to get all the staff to have it sorted for you in the middle of the night. 3 o'clock in the night, can you do it? I'll challenge you with that. Another piece of equipment which we're starting to use in Leicester, I don't know if you've come across it, which is the Oxford Help, which is HELP stands for Head Elevating Laryngoscopy Pillow. Okay. Now, if you have a fat woman and you need to either put them to sleep in a hurry, I don't know if you ever tried rumping, which is what the bottom here, using pillows. You know, that can take 10, 15 minutes. It's pain trying to get somebody. Whereas if you use these pillows, you just put them on and the patient lies on them. So they're very quick and they're very useful. Again, we haven't got them in a hospital because they won't buy them, they're quite expensive. So we have to hire them. So we only hire them when we know there's a patient who's pregnant, who's overweight. Now, if you needed this patient just comes through the door and you haven't got them, you're down to using the ordinary things that take longer. CMAs just come out, and unfortunately, we're still not doing very well, are we? Look at this, this is 1985, and it was 6 deaths, direct cause deaths. And there we are, still 7. So we're not doing well. And 3 of these were due to airway. So we have to address this. Difficult airway is still a big issue in obstetrics. And we've got to try and reduce it. Hence, we shouldn't be doing it during the middle of the night. We should be doing it during work time. CMAs has shown us again that obesity is a big problem, and it's going up. They did this study, which was looking at obesity within an obstetric patient. What the study showed was that 5% of pregnant women have a BMI of greater than 35. In Leicester, we have a unit that's 10,000 deliveries. We've got 2 units doing together, 10,000 deliveries. So we would have 500 patients a year who are greater than BMI of greater than 35. 2% a BMI greater than 40, which equates to 200, and 0.2%, 20. So every 2 weeks, we probably have somebody with a BMI of greater. Again, obesity, the study showed that cesarean section is higher, 37%. So even if you wanted them to deliver normally, they still end up in theatre, okay, because section is higher. And also they have postpartum hemorrhage is high in the pregnant women. So I've looked at trainees, I've looked at ODPs and equipment. Let's look at consultants. And in this, I probably include obstetric as well, not just anesthetic consultant. In the middle of the night, are you going to be able to get people over in a hurry? It's not easy. You can do it, but it's not easy, okay? So we need out-of-hours support if you want to do these difficult patients. And also, in our hospital, if anybody's a new consultant, because they're less experienced, they never go on call as soon as they become a consultant. They have a 3-month grace where they cover or they cover with somebody else. So we have new trainee new consultants who are less experienced than we were when we were going to this consultant. Now, if I move on to, if you had a patient that is a known difficult intubation, what might you think of as options if you want to give an anesthetic? Well, the normal is regional, obviously spinal and CSE, but there are times that you need specialist procedures, such as awake fibre optic intubation or continuous spinal anesthetic, which we've used in no difficult intubation patients. So, are we prepared for that? Our consultant colleagues are prepared for this. Well, let's look at awake fibre optic intubation. A survey done by Mansfield Popat in 2000 looked at what would be the choice of anesthetic for a known difficult intubation. And they found that obstetric anaesthetists, 83% of them would choose awake fibre optic intubation, which is wonderful. Okay? Trainees, 100% wanted awake intubation. However, if you ask them, were they confident actually in doing awake intubation? Went down to 39% of the consultants and 63% of the trainees were confident in doing an obstetric awake intubation. Now, when you move further and you say to them, have you actually ever seen or done one? Only 8% can do an awake intubating obstetric patient. Okay? So in the middle of the night, you're going to be able to find anybody out of those 8% who's going to be able to come and help you doing an awake intubation. No. Okay? Spinal catheters is another one that you may use in a difficult difficult intubation scenario. A survey done in 2009, they showed that only 6% of units in the UK actually use spinal catheters. Failure rate is very high. So again, if you need it in the middle of the night, are you going to be able to have somebody to come and help you? Okay, no. I'm just going to very briefly talk very quickly about some case reports that we have and how we manage them. First one was a lady who had rheumatoid arthritis from the age of 14. And I don't know whether you can see on the x-ray there, but you can see the gap, the transaxial gap there was 5 millimeters. And she presented to our clinic. Now, how would you manage that if you're coming? Would you want it to come in the middle of the night, you know, and do a delivery or whatever you want to do? Personally, we decided not. We went for elective cesarean section because everything could be done under control and did anesthetic. And fortunately, we did because at cesarean section, she had fibroids, she had compound presentation, and she had a uterine tear. So section itself wasn't straightforward. So we were quite pleased that we did it during the day. The next patient we had was this lady with Conradi-Huninen syndrome. Now, don't be alarmed if you don't know what it is. I didn't know what it was when I was phoned in at 3 in the morning to say that she appeared on the labor ward, this lady. Basically, the main problem is the curvature of the spine and the mid-facial, so they're really quite difficult to intubate. She was 30 weeks pregnant by the time she presented, but fortunately we were able to delay her delivery till a few weeks later when she became elective section. And the history that she'd had spinal operations, you can see in her back there. She had an awful airway, limited neck movement, couldn't move her neck at all, and she was very short, very short, very difficult to palpate. So how did we do that? We then found out she also had a Chiari malformation, and her cerebella was herniating through a foramen magnum. How do you do that? We did an elective section, all right? Continuous spinal anesthetic or wake intubation. She refused awake intubation, so we ended up doing continuous spinal anesthetic. And then we had Klippel-Feil syndrome. How do you do that? She had limited neck movement. This is the lady. This is her trying to actually extend her neck. And she'd had 2 previous sections, and she couldn't breathe under spinal anesthetic. So that's her X-ray. How did we do that? Elective section and awake intubation. Would you get that in the middle of the night? No. There we are. So in summary, I've looked at training issues, ODP, recovery, staff, and equipment, what CMAX is telling us, and consultant issues and experience, and then some case reports. So, I know my opponent might try and push you to say that, well, don't do a cesarean section, just induce them. But I know that most of the inductions end up in cesarean section, and the cesarean section is about double compared to when it's just spontaneous onset of labor. Should patients with no difficult airway have an elective cesarean section? I think the answer is yes, 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 because we don't want to have any of that. Thank you very much.